Good morning, everyone. Welcome to our webinar. We will get started in just a minute. Good morning. For those joining us, welcome to the Diabetes in Special and Vulnerable Populations, a national learning series. We will get started in about 1 to 2 minutes, giving people time to log on. All right, good morning. I'm going to go ahead and get started. My name is Cindy Selmy. Welcome to our webinar today, Understanding Social Determinants of Health and Structural Barriers Affecting Diabetes Care. We're really happy you're able to spend some time and join us this morning. Just a quick word, diabetes affects 37 million people in the United States. And this is the third year the Special and Vulnerable Population Diabetes Task Force has engaged health centers and other health organizations by hosting the National Learning Series. This series is funded by HRSA and the Bureau of Primary Health Care as part of the Health Center program. It is in response to the 1 in 7 health center patients that have been diagnosed with diabetes and the 1 in 3 patients that are challenged to control it. We are taking a multi-tier approach to address, prevent, treat, and create management strategies for diabetes care. And we welcome you to visit our website, chcdiabetes.org, to learn more about our work. There are 14 national training and technical assistant partner organizations that make up the Diabetes Task Force. These are our logos, and you can find out more about us on the website. Today is just the first of a series of 4 webinars that the NTAPs that are part of the Diabetes Task Force are having for you, and it's definitely not too late to register for the other webinars in the series. Please join us Thursday for webinar number 2, Intersectional Identities of Health Center Workforce and Patients. And next week, we're pleased to bring you Emergency Preparedness for Diabetes Management, as well as our final webinar in the series, Environmental Impacts on Diabetes Access to Care. This webinar is eligible for CEU units, And the faculty presenting today have no real or perceived conflict of interest. We have no commercial relationships with any pharmaceutical or biomedical companies. And if you wish to pursue CEUs, please contact Jillian Hopewell with the Migrant Clinicians Network. Jillian's email is at the bottom of the slide, and she will take you through the process of receiving credit. I am so excited to introduce our faculty today. First, I want to introduce Jamie Blackburn. Jamie is a Senior Program Manager of Federal Technical Assistance for the Corporation of Supportive Housing. I'm also happy to welcome my colleague, Abba Anason Amu, Program Manager at Health Outreach Partners, and Darlene Jenkins, Senior Director of Programs for the National Healthcare for the Homeless Council. And I am Cindy Selmy, Executive Director at Health Outreach Partners. We will all be presenting for you today. All right, we have 3 learning objectives for our webinar this morning. Number 1 is to understand how social determinants of health affect under-resourced communities' access to healthcare service. 2, to identify the root and structural causes of health disparities due to access to SDOH, such as transportation, housing, and food insecurities. And lastly, to identify and implement effective strategies for SDOH interventions at local health centers. So with that, we're going to start to dive in. This is Dr. Jack Geiger, and he is one of the founders of Community Health Centers. And even at their inception, community health centers looked at the whole person and addressed the social determinants and the risk factors that affected people's overall health. And with that, I'd like to share with you this slide that shows a map of our country looking at diabetes prevalence across the United States. This map is taken from 2018 data, and the darker the counties appear, the higher the prevalence of people who have diabetes. In some of the darkest blue counties, the diabetes rate is over 10.5%. And what is really evident as we look at this map is that diabetes has an uneven distribution across our country. And if we look at the counties in the red circle, if we see right here in parts of Colorado, there is a very low rate of diabetes. And when we compare that to the counties in the large red oval, we see in this cross-section of states, which is in the southeast part of our country, there are much higher prevalence of diabetes in those counties, so much so that in some of those counties, people's diabetic rate is over 11.7%. And the CDC at one point referred to this part of the United States as the diabetes belt. And you know, this is quite a difference from the counties in Colorado. And oftentimes when we're talking about diabetes, the explanations around the causes of diabetes tend to focus on things that are about the individual, such as genetic susceptibility, individual behavior, and recommended care and interventions focus on making lifestyle changes, as well as around diet, exercise, and taking medication. But as we look at this map, we have to recognize that there is something going on beyond the individual if diabetes is having such a large-scale impact, but also inconsistent by region. The second map looks at counties in the United States that have consistently persistent poverty. And the counties that are in the darkest shades of red have the highest levels of persistent poverty. And when we're able to compare these two maps side by side, there is a strikingly similar pattern between the counties that have high prevalence of diabetes and high prevalence of poverty. This is why we think it is not enough to just consider health disparities, but the factor of poverty, and even further, what's causing poverty. These large-scale influences are what we at HOP are collectively referring to as structures, and they contribute to health outcomes. So what is a structure? For the purpose of our discussion today, we will use the following definition of social structures. Social structures are the policies, economic systems, and other institutions such as schools, the judicial system, and other government systems that have been produced and maintain modern social inequities, as well as health disparities, often along the lines of social categories such as race, class, gender, sexuality, and ability. So we have this problem of health disparities where we often see it reflected in the health outcomes of our specific communities, such as higher level of maternal mortality rate for Black mothers across all income levels, or in the rates of chronic conditions such as hypertension and diabetes, as is the case of our discussion today. And we are seeing this also with COVID-19. As the pandemic has raged on in our country, Black, Brown, and Indigenous communities are being hit the hardest. So in trying to find solutions or to explain these health disparities, our attention has shifted to identifying the social determinants of health, which means specifically poverty, inequality, lack of access to safe and effective transportation, housing, and food disparities. These factors contribute to health and well-being, and access to them also contributes to either wellness or lack of access to health outcomes and health disparities. But there has been little attention in the health sector in looking at the larger factors created that create these inequalities, such as policies, economic systems, and social hierarchies, particularly racism and white supremacy, that affects these social determinants of health. These are the structures that we are referring to, and we at Health Outreach Partners rely on the structural competency framework that aims to do and builds upon existing frameworks that are used to understand and explain health disparities. We refer to this as the structural competency framework. Specifically, structural competency is about recognizing and understanding the policies and economic systems and social hierarchies that underlie poverty and inequality, and therefore contribute to disparities in health and healthcare. We use the phrase, the structural determinants of the social determinants of health. And with that, I'm going to invite my colleague Abba to share with us about transportation and its role in diabetes care.
Thank you, Cindy. Hi, my name is Ava, project manager from Health Outreach Partners. I'm going to talk about transportation and how it affects diabetes care. The cost of automobiles due to factors like gas prices and maintenance is a a huge concern for people to access care. Another critical barrier that affects special populations and their families is the ability to obtain a driver's license without proper documentation in most locations. Also, most specialists and pharmacies are not within walking distances, and sometimes hours of operation can be a problem for special populations to access easily. Other non-health needs like accessibility to good grocery store are essential for the well-being of a diabetic patient. Also, low income levels create the need for people with diabetes to choose from what is urgent need for a healthy lifestyle, like eating well and exercising when they can work to earn more money. Next slide, please. Let's look at some resources available. Most public and Medicaid transportation system isn't always accessible in most rural areas. In some cases, people do not meet the income requirements. Hours of operation are very unreliable, and this poses as a risk for people with diabetes when they miss important appointments with their health practitioners. Ride shares like Uber and Lyft may not be easily accessible in some communities. This type of service requires the use of smartphones, making it undesirable for most patients, or even those without smartphones. Also, the long wait times to access public transportation can affect the person from getting to their health centers in a timely manner. Bad weather, bad waiting conditions like excessive heat or cold poses as a health risk to people living with diabetes. The fear of missing a bus or a ride when waiting inside a health center is a reason for people to wait under these bad conditions. Next slide, please. And here are some solutions that have shown to help bridge the gap between diabetes care and the social determinants of health. Health centers should attend committee meetings in communities that they serve to assist in the implementation of road and transportation systems. Incentives like vouchers and the provision of rides by partnering with local community organizations will help curb some of these missed appointments. Hosting of mobile clinics in local areas where transportation may seem difficult to the patient. Outreach and resources are also another medium by which we can help educate and create trusting relationships with patients. HOP has a great resource on outreach and transportation. According to the GOA, telehealth usage increased from 5 million to over 53 million between April and December of 2020. This shows that the use of telemedicine is an effective and efficient way to treat people. Monitoring glucose levels can now be done with technology of Bluetooth connectivity and other medium, making it much more convenient for people to communicate with their health providers without leaving their homes. Next slide, please. As I mentioned earlier, HOP has great resources like our Transportation and Health Access Information book that has basic data and also information that you can use to help bridge barriers in transportation and health, and a couple of other resources that have case studies around different organizations and how they work around issues of transportation. I personally find this to be very innovative work because I believe that your respective organizations can utilize this too. We also have a transportation quality improvement toolkit to help create awareness of the barriers of health and transportation that can be tailored specifically to your organization needs and find solutions to them. Please check out these useful resources on our website at www.outreach-partners.org/resources for more information. The link will be dropped in the chat. And at this time, I will pass it on to my colleague, Darlene, to discuss food insecurities. Thank you.
Great, thank you so much, Abba. I appreciate the information that you gave. I'm going to focus a little bit now on food insecurity. And I just want to kind of do some level setting where we're all familiar with the terms that we often hear. Let's start. I'm not going to read all of them, but I'm going to just start talking about or look at captive food populations. This is a term that is often used for people who are unable to travel for food or travel far for food. And that can also be described as, Abba was talking about those who have the lack of transportation. This term is often used for those who are unable to, they don't have transportation, or they may be too ill to travel, or they are just have the inability to get to the food. And so we're often using that term, captive food populations. Another term I want us to look at is also food justice. That is another term that has been used frequently now as we talk about how we address the structural barriers to food. And so it is really looking at a holistic and structural view of the food system. And it also sees that having access to food is a human right. And so it's really getting down to how do we ensure that everyone has access to healthy food, which is so important. I think we all have experienced, at least I did, we experienced food mirage. I was at the store the other day, I wanted grapes and they were like $6.99 a pound. And I said, no, I can't pay that. So food mirage is also when grocery stores are plentiful, but the prices are beyond the means of low income populations. It could also be beyond the means of those who may not be in low income populations, but you will also hear this term used in this instance. Next slide, please. And then there's also food sovereignty, as you can see the definition there. Next slide. I want to spend some time, especially talking about food deserts, because we use this term often. It was a term that started in 1990 in Britain, and we adopted this term in the United States. And it's often referred to an area where there's no fresh or nutritious food available. Many times they also just say that people live in food deserts when they say that there's no grocery stores. So this term is used often. We hear this term used when referring to people who may not have a grocery store within that's close to in proximity to them. But I really want us to consider the term, even though we use this term and it's a common use, I want us to really consider, is this the correct use of term? So this summer, my husband and I were driving across, we went to California. I live in Nashville, Tennessee. So we drove across we drove to California from Nashville and then back, and we drove across the Mojave Desert. And it was a beautiful place, but it was very, very hot. And so as I looked across the Mojave Desert, I mean, it crosses 4 states, California, Nevada, Arizona, as well as Utah. And I saw just the natural beauty of the Mojave Desert. So when I look at the Mojave Desert, this is something that occurs naturally. There was not someone who came and piled all this sand and cacti in this across these 4 states. It occurred naturally. To use the term food desert when we're talking about individuals who don't have access to healthy food is really ignoring the structural barriers that occurred that created the food desert. Food deserts are not natural. They are actually the result of decisions that have been made where urban planners or the city has decided that they're going to build certain foods in a certain area where supermarkets have decided to move from the area where they are currently possibly located. So I just want us to make sure that as we use the term food desert, that we really understand that food deserts are not natural. They are decisions that have been made. And also a desert gives the impression that there's nothing that exists. In a food desert, food does exist. It's just not the healthiest type of food. So as we talk about structural barriers, let's also think about how we can really correctly address and identify some of the things that are occurring in our society. You'll hear the term now, food apartheid, and that is a term that is being used more frequently because it really addresses the inequities in the food system that exist, as well as looking at how we have redlined supermarkets. We know that redlining for housing is illegal, but redlining for supermarkets are not illegal. And many times based on the community, based on the residents in that community, supermarkets may decide not to go into this area because of the population that lives there. Next slide, please. Two terms that also I would like us to understand as we talk about the structural barriers to especially access to healthy food. It's food security and food insecure, being food secure versus food insecure. And it's really a continuum as we look at just having access. So when you have high food security, that means that you have access to nutritious and safe food. You don't have to worry about what you will eat, your next meal is coming from. Then you have high food security and you have low food insecurity. But then as you move down the pyramid, you can see where you have low food security. So that means that you have a higher rate of being food insecure. And then when you're very, very low food insecure, then when you have very low food security, then you have our high episode of being food insecure. So just want to make sure that we're understanding the relationship between being food insecure as well as being food secure. They are, the correlation is an inverse correlation between having food insecurity and having access to healthy food or being food secure. I want to also note that hunger is not the same as being food insecure. Sometimes we use those terms interchangeably, but they are not the same thing. Hunger is a feeling that you have when you do not have access to food. So hunger is the feeling of not having food, whereas food is not having the access to the food. Next slide, please. So let's talk about the root causes of food insecurity, because that is really something that we want to address. You know, we cannot look at all the different, evidence, the leaves of the tree, the branches of the tree without getting to the root of it. And these are just some of the listings of the root causes. It's a multi-layered, problem. There's not just one issue that we can point to that says this, if you're this, that, the other, you are food insecure, but it is multi-layered, multifaceted. And so we want to make sure that we understand that a person who is, as was mentioned before, poverty, where Cindy showed that relationship between poverty as well as the high incidence of diabetes. Poverty, unemployment, or low income, underemployed makes one more susceptible to being food insecure. Also having the lack of affordable housing, chronic health conditions, and having lack of access to health care. Research has found that individuals that access health care seem to have also access to better access to food. So there is a positive correlation between having access to healthcare as well as having access to food. And this many times can be based on having access where the healthcare system or the health center is actually referring clients to food pantries and also addressing the food insecurity for their clients at their health center. And then, of course, we talked earlier about systemic racism as well as racial discrimination. All of these are root causes for individuals and populations to be food insecure. Next slide, please. So this is a map that kind of shows the food insecurity in America. This are the states, and the states that are blue have a higher rate of insecurity than the nation. The nation, about 10.4% is the average of people in the nation that are food insecure. Mississippi has the highest rate of individuals who are food insecure at 15.3%. I put the source here that Feeding America, you can go in and access this map. You can see your state. They also have one for the county. So it really is important as you look at food insecurity in America, just to understand where food insecurity is, as well as how it projects in your state, as well as in your area and county. Next slide, please. For individuals who are in Black as well as Hispanic households, they do experience a higher rate of food insecurity. Again, this is talking about the racial and systemic racial barriers that exist in our society. For the overall household food insecurity, you can see the higher rates there for African American and Black. It's 21.7%. For Hispanic, it's 17.2% of households that experience food insecurity. So this is something, again, that we really want to acknowledge as well as to address when we are looking at how do we find solutions for the food insecurity that exists in our communities, as well in our neighborhoods, as well as our state. Next slide, please. Now, when we talk about diabetes, there is a correlation between diabetes as well as being food insecure, as this map shows. This is just an overall map that kind of gives you an idea of just not only the incidence as well as the number of people who are diagnosed with diabetes, but also those who are undiagnosed. And then I want to just bring your attention to the bottom where it says the population health impacts, where it shows in 2018, individuals who were food insecure, 1 in 5 that had A1C of 6.529, 1 in 5 were food insecure. But as we go to get farther on the continuum of time, we will see that unless we address food insecurity by 2050, 1 in 3 adults will have type 2 diabetes, and then 1 in 4 with an A1C greater than 9 will have food insecure, will be food insecure. So it really does, no, it does not differ. I see the quote, the question here, does not differentiate between diabetes type 1 and diabetes type 2. This is just overall the prevalence of diabetes in our society. One thing I do want to also mention is, as practitioners, as healthcare providers, as we look at really addressing food insecurity, really, when we're talking about diabetes, A1C is one issue that needs to be addressed, and understanding the relationship between our clients and patients being food insecure and being able to regulate their glucose and really having good success as far as good numbers when it comes to A1C. But I also want us to also think about, and this is on the next slide, when we are providing care to clients, that a nutritious diet, having access to nutritious food is essential, is necessary for healing, for wound healing. I know as a registered dietitian, when I worked in the hospital, many times I would have patients with diabetes who had abscesses, who had decubitus ulcers, who had foot ulcers. And the first thing that we would be asked to do is to put them on a high protein diet. And if indeed a person does not have access to nutritious food, which includes high protein and low carbohydrate, and especially simple carbohydrates, which are sugars and snacks like chips and things of that sort, which is very prevalent in, again, food when we're talking about communities that have an overabundance of fast foods. It's very difficult for a person to heal when they don't have the proper nutrition. And so it really behooves us not only to think about, as we are interacting with our clients with chronic illnesses and with wounds and with other issues, blood pressure and diabetes, that nutrition it plays a very, very important part in getting a person well. And again, as we think about health equity and how do we change the systems, the structural barriers, how do we address the barriers, we need to ensure that we're getting to the root and attacking the barriers that are standing in the way of a person having access to a nutritious food. Next slide, please. So Dr. King calls us to a consciousness where we need to have direct action. It is a consciousness to be aware. I think it is being aware of what is going on, being aware of how we can come up with solutions, not just, as I said, even going back to food deserts, we repeat terms and we really aren't understanding just what type of ways that we're capturing some of the things that are systemic in our society. So I call you back to an awareness, a consciousness where we can really have make a difference in our society if we are really conscious of and intentional about our solutions to the issues that we are facing. Next slide, please. And I hurriedly want to share two solutions in particular that have been used by health centers recently to address food insecurity for their clients. This is a food map that was developed by Zufall Health Center in Dover, New Jersey. The National Healthcare for the Homeless Council, our organization, just finished 2 cohorts of helping health centers develop food maps in for their community. This is something that is done through Google Maps. It's very easy, that can be done. They decided to do the food map, and they have on here a pantry where you can find pantries, where you can find free markets, where you can find a soup kitchen. They have WIC and SNAP retailers. We also helped health centers develop maps where they have transportation routes that can show clients where and how to get to the different food resources in their communities. So food mapping is a solution that you can use to address food insecurity in your community, as well as for your patients and clients that you serve. And then this is just a link to the food map that was shared with us from Zufall Health Center. Next slide, please. And then a second solution that we are seeing now is the produce prescription program. This is one of the programs that Unity Health Care in Washington, D.C. has. Their physicians actually write prescriptions out for food, and they work with the farmers market as well as other partners in their community to address food insecurity. So this is something that can be also considered when we're looking at solutions to address food insecurity in our community. Next slide, please. And this is just a slide of some of the resources. Also, I just wanted to highlight some of the other solutions that health centers have done. One health center in Massachusetts did a hot house. They got grant funding to have a hot house on their parking lot, and they grew fruits and, well, not fruits, I'm sorry. They grew vegetables in their hot house to distribute to their clients. You can also get a community garden. I know many health centers have partnered with other agencies in their community to do community gardens. Health centers have also stood up medically tailored food pantries at their health center, where you take a space and you actually have places where one can access food, where it is color coded. So for someone who is diagnosed with diabetes, they can go in, and if they see food that have a yellow dot on it, they know that that is something that is diabetic friendly, and they can pick those foods and actually have access to food that is tailored to their illness or their disease, their chronic disease. And then again, we talked about farmers market. I know that is something that many health centers are starting to look at. So with that, I'm going to hurry on because I know that Jamie has something very, very good when it talks about housing and the structural barriers. So I'll turn it over to Jamie at this time. And thank you so much for your attention.
Thank you so much, Darlene. And thank you to everyone who's commenting in the chat with your suggestions. I see Caitlin just shared a food prescription program guide for your health center that they use. So thank you to everyone who's chiming in the chat. And thanks, Darlene. That was really, really great. And I'd like to talk to everyone now about another really powerful social determinant of health, which is access to quality and affordable housing. So I love this infographic that comes from the National Low Income Housing Coalition because it really shows that no state in this country is immune from the national housing crisis and the national shortage of housing. I think we've seen that across the board, certainly in all of our communities. Rents are skyrocketing, and it's very difficult for folks that even those individuals with very low incomes that have access to voucher programs such as Section 8 are often unable to find units even if they have a voucher in hand. And this is because the supply across the country is very, very low. And this map sort of outlines where there are the lowest amounts per 100 amongst, especially for the lowest low income renter households. And so unsurprisingly, the bigger states, California, Florida, Texas, have some of the biggest gaps. Next slide, please. So, housing is such a powerful social determinant of health, and really lack of housing, lack of quality access to housing can really lead to enormous pressure on a number of different systems, not just, the healthcare system, but we see high costs and poor health outcomes. And we see, higher emergency department visits, longer stays in shelter, hospital readmission, jail, cycling in and out of jail, psychiatric, inpatient. Housing instability really has a large reverberative effect across multiple sectors, and really has a strong impact on the ability of someone with diabetes to really adequately access care and then manage their care and be an active participant in their care. Next slide, please. And there's a lot of research that shows that housing is often one of the most powerful social determinants of health, and that this research is really showing us that it has more of an impact on outcomes for diabetes than any other determinant. This recent research, and I can drop these. You'll have these citations if you are interested in diving in to some of the literature yourself. That will be available to you when you have the copy of the slide deck. But this research has found that what the researchers are calling neighborhood disadvantage was found to be what they're calling a contextual risk factor that impacts the self-management of diabetes. And so housing really has this really deep impact on diabetes care. And it's something that health centers are paying more and more attention to. And we're going to get into some of those practical steps that health centers can take around housing. Next slide, please. So some of this more research around housing has shown that patients experiencing housing insecurity, so not necessarily has to be direct lived homeless. It doesn't have to be actual literal homelessness. It can just be housing insecurity or instability, are less likely to have a physician visit, are less likely to have an A1C check, and are less likely to have an eye exam, which one particular study found. Unstable housing is also associated with increased emergency department visits, inpatient use, and that research again and again and again recommends addressing housing instability in clinical settings. So as health centers, housing, can often addressing housing can feel daunting. Healthcare sector, this is healthcare and housing are often two very, very separate spheres, speaking different languages, having different funding sources, and it can, those cross-sector collaborations and partnerships absolutely exist, and I'm going to get into some good examples of that. But by and large, these two sectors tend to stay in their lane. So sometimes it can feel a little bit overwhelming and daunting. How can we address housing insecurity for, our patients? And some of the best steps that we can certainly recommend for that is threefold. So connecting to what existing resources there are in your community. So such as a continuum of care, which I'll get into in just a second over what these mean, or your local public housing authority. A continuum of care is for folks experiencing literal homelessness or at risk of imminent homelessness. Public housing is really more for folks that are low income, but maybe are not meeting those strict definitions of homelessness. Deeper partnerships, right? So partnering with the housing providers in your community, the housing sectors, and exploring other efforts such as capital expansion, of which CSH offers a number of different HRSA-funded resources around capital expansion, and essentially becoming an active player in creating new housing in your community, and lending the healthcare sector weight behind existing housing advocacy efforts is really powerful. And those cross-sector collaborations are going to make those efforts stronger. And the housing sector really wants to partner with the healthcare sector. And so, reaching out and making those collaborations are really key to ultimately connecting your patients to the housing resources that they really need. So a continuum of care is the group of organizations in your community, and every location is going to be a little bit different. They're not geographically defined in a uniform way across the country. Some COCs are city-based in metro areas, some are county-based, some are an entire state, like the state of Maine. There is one COC for the entire state. So it's really important to find out, do I live in a city-based, what is your local COC? It's very easy to find out. You can typically Google it. And I can also drop a link on the Finder tool that HUD, the Department of Housing and Urban Development, maintains for you to find that contact information for your local COC. So the COC is all of the organizations that receive federal dollars from HUD to operate emergency shelter, permanent supportive housing, transitional housing. They do street outreach, intake, and assessment for those resources. There are certain standards of quality that HUD maintains, certain standards to become a member, but it's very, very easy for health centers to join their COC should you choose to do so. And we certainly strongly recommend that you do. So if you are serving patients that are experiencing homelessness, or if you're seeing an influx of patients that are at imminent risk of experiencing homelessness, your local continuum of care is your place to go to look for those resources to serve those patients. There will be a waiting list. They are screened. There's an intake process. Some localities, so some COCs will use what we call a no wrong door. And this graphic here is from the Wisconsin Balance of State COC, which means any agency that's in the COC, you can walk in and you can do an intake right then and there to get placed on the waiting list and the priority list for those housing vouchers and resources. Other places have a centralized intake process, such as a 211 hotline. So for instance, in Connecticut, they have what's called coordinated access networks. You call 211 and everything is centralized. So every location does it a little bit different. It's really important to inform yourself on what process your local COC takes so that you can make those referrals for patients that are experiencing literal or imminent risk of homelessness. And there's often, next slide, please. Housing resources are really scarce. in every single community. There is a wait list. It doesn't matter which pathway for resources for housing you're looking for, there is a wait list. So one way to, as I say, level up your connections to try to make sure that your patients are actually getting connected to the housing resources that they need is to directly partner with your COC and have a really strong partnership. And there are ways you can join as a member of your COC and attend those monthly meetings, join a committee. You can act as a referral partner. So that's an organization within a COC serving individuals and families. And they would make those referrals to what's called an access point, where they'll do that assessment and intake for prioritization for those resources. Or you can actually serve as an access point yourself for your health center, meaning you are screening for housing insecurity. A patient has screened positive for housing insecurity or homelessness, and you can refer them to somebody in-house who can do the intake same day and get them entered into the homeless management information system and get them on that waiting list as quickly as possible. And I strongly recommend, we've also, CSH also has a number of other resources that go more in depth into this around becoming an access point for your COC and what that looks like. We certainly strongly recommend, because it eliminates any potential pitfalls or ways for patients to fall through the cracks in that referral process by taking it in-house. So this is certainly options. And often these resources, the communities determine for themselves how these resources are prioritized. HUD has very basic guidelines for COCs to implement what's called coordinated entry, which is how these resources are doled out. Some communities will say, we want to prioritize homeless families with children first. Some communities will say, we want to prioritize senior veterans before everybody else. And each community, each COC will make those determinations themselves. And by being a member, you can weigh in on those decision-making points on what constitutes a priority for housing. And sometimes it comes down to case conferencing around these resources when a name comes up on a list or when resources become available. And being at that table ensures that your patients don't get lost in that shuffle. So if you want to learn more about the coordinated entry process, access point referrals, CSH recently with HRSA funding created a guide for health centers all about coordinated entry, getting in more in detail. So we can link that. Here. I strongly recommend that you check that out. Great. And so now I want to talk just a bit about new housing creation. So certainly we can connect to the existing resources in our community. That's fantastic. That's definitely the first step that we want to take. But looking more long term, as we know, there is not enough resources. There's simply not enough housing stock coast to coast to meet demand. So even if you manage to get your patients on a waiting list, even if they manage to get a voucher because they check every box of vulnerability and need, and let's say they're able to get a voucher, under the CARES Act, there recently were 70,000 new emergency housing vouchers released to public housing authorities across the country, and a huge majority of them are still unused and unleased up because there's simply not enough stock to take advantage of. So how do we address this long term? And that is, we have to create new housing. There's no other way around it. And it can't be done by housing advocates alone, right? We need cross-sector collaboration with healthcare in order to generate the new housing stock that we need to address these social determinants of health and ultimately move the needle and get to the health outcomes that we're looking for, particularly around diabetes. So tell me in the chat if your health center is already connected to or has existing partnerships with housing organizations or your COC. I'd love to know. Next slide, please. And so I'd love to highlight one really excellent example around capital expansion and how health centers can really be active players in their community to add to the new supply of permanent supportive housing or deeply affordable housing for special and vulnerable populations, right? We also often see health centers playing a role in creating respite beds, access to respite resources, which meets a huge community need, or even workforce housing, which also plays a role long term, because we cannot bring online the units of permanent supportive housing that we need to serve the most vulnerable in our communities without the service providers to meet those needs with the wraparound services. So this is very important. So I love an example, this example. This is Paseo Verde in Philadelphia. They engaged in a capital expansion project, which provided 21,000 square feet of program space for the human services providers, over 7,000 square feet for an FQHC, on-site pharmacy, and 120 units of housing. So this is, I love this example because it really shows how, and we have numerous examples like this, and certainly if you are interested in exploring this option for your health center, CSH offers one-on-one technical assistance around all things housing and homelessness and particularly around capital expansion for your health center. And we are really generously funded through HRSA to provide this for health centers. So if you're interested in learning more about that, please reach out to us. Great. So another way beyond capital expansion, which is a big step, right? And that's not something that all health centers, yes, can engage with. And I just want to shout out Michelle's comment in the chat about Central City Concern Blackburn Center. That is a wonderful, wonderful example of a national best practice of integrated health and housing services. Highly recommend. We have a wonderful relationship with them, actually, and often talk about the successes of that particular model in forums just like this. So thank you, Michelle, for bringing that up. Wonderful example. Okay, so I know we only have a few minutes left, but I want to just address there are other pathways, right? So capital expansion might not necessarily be the right pathway for everyone, and not every health center has capacity to do that. So how else can we be active players to engage in upstream, longer term solutions to create new housing to address social determinants of health and ultimately affecting diabetes care? So two of my favorite examples are part of lending that sort of that advocacy bent and partnering with existing advocacy efforts, housing advocacy efforts in your community. So you don't necessarily, contrary to what might be a common opinion, is that you don't need new legislation, you don't need new appropriations necessarily to increase the supply of housing in your community. There are ways at the state level that a health center or a group of health centers can come together to advocate and lend their voice. An example of that would be what's called a qualified modifying or providing comment on a qualified allocation plan, also known as a QAP, or providing input to a consolidated plan. So there's a public review and comment period for both of these things. And there's ways that, and it's a time where advocates can weigh in around their, their specific goals and priorities for how housing resources should be allocated. And this is a really important period. These public comment periods are required, and anyone can jump in. And it's really important. So for example, sometimes a QAP only has a general statement, right? Or of goals, of what, it can be sort of more gray, but advocates can actually can provide comment and can weigh in to get very specific, what we call set-asides, so that certain amount of units created with state dollars under these programs can be set aside for highly vulnerable populations, or preference points in the scoring, if you will, for priorities in a QAP. And I'm going to show an example of this on the next slide. Well, on the next slide of that, but in this, a qualified allocation plan if you could go back one, thank you. A qualified allocation plan is through your state or local housing finance authority. A consolidated plan comes from HUD. So these cover the community development block grants, home investments, emergency solutions, housing for people with AIDS, National Housing Trust Fund. These are all of the things, the funding sources that are guided under the consolidated plan. And so these are public dollars, and there is a public comment period where, and these plans really matter and make a very big difference in the type of affordable housing that is created in your state. Next slide. So the QAP sets out what is your, which is the qualified allocation plan for your state, typically sets out the priorities for awarding, federal LIHTC for housing, right? So that's low income housing tax credits, right? And so we want more affordable housing in our communities to serve the most vulnerable. And so there's certain ways that these qualified allocation plans can incentivize developers to create more affordable housing. And when you have a strong QAP that has strong preferences to serve vulnerable populations, this can be a really powerful tool without having to raise any new money or pass any new legislation, right? So for example, in the interest of time, I'll try to breeze through this as quickly as I can. So for example, in Minnesota, they recently updated their plan. They have about $14 million for their funding, and they have set out priorities to serve folks with the highest need, largest barriers, lowest incomes, and to preserve existing subsidized housing. And they have created a scoring system that incentivizes projects that are there to serve the most vulnerable in their communities. And certainly not every QAP does this by any means. Some are quite vague on how they're going to prioritize. And if folks are interested, I can link you to an analysis that CSH does. We have a tool that will show you what your state QAP does or does not do in a very simple chart. But there's a public comment period every year. And perhaps your PCA or your HCCN or even just your health center would like to weigh in, this is something that is a very valuable tool. All right, as a final takeaway on this, housing is the most important, and we certainly believe that housing is the most important social determinant of health. It is the platform that all future endeavors can be built from for our most vulnerable patients. And so I strongly encourage you to become a member of your continuum of care if you are not already. Identify some existing cross-sector collaborations internally at your health centers to make sure that you're not duplicating efforts. Reach out to your local housing advocacy coalition, connect with them, see how you can support their existing efforts. Provide a public comment on the next open period to your qualified allocation plan or your consolidated plan, which governs the federal funds. And then consider your role within your health center in a health and housing partnership to create new housing, maybe as a service provider, maybe through capital expansion and creating new units, as we saw in the Paseo Verde example. But these are longer term upstream solutions that are really going to move the needle around social determinants of health structurally. And then finally, if your health center is not ready to take any of these steps, I would strongly encourage you to act as an internal champion, making the case to your decision makers about why joining your COC is so important. And so I just want to thank you all so much. I will drop the QAP link in 1 second. And in the meantime, if folks could please follow our evaluation link, your feedback is so important to us. I think many thanks to everyone for staying on. I know we are at time. And also, if you have not registered for the second webinar in this national series, is coming up this Thursday, December 8th, where our NTAPs are talking about intersectional identities around health center workforce and patients in the context of diabetes. So I definitely encourage everyone to check that out. I just want to say thank you all so much for your thoughtful questions in the chat and comments.
All right. Well, thank you, everyone, and have a great day and reach out to us if you have any questions. Bye.